Hello, Dr. Nandita. I would request the participants to start the presentations.
अरे स्पीकर्स नहीं आए अभी लेकिन सारे कर लो
Dr. Nandita, whether other speakers have joined?
लेकिन ये कर लिया तो फिर वो कैसे होएगा मुझे वो कैसे देखेंगे पैनलिस्ट को ठीक है करूँ मैं F5 कर दो
Hello, Dr. Nandika.
अटेंडेंस में आ रहा हूँ यार मेरा नोट कैसे करूँ मैं अपने आप Good afternoon, everyone. Sorry for the little delay. We are just waiting for our chairperson to kindly to join us. We'll be just joining in a moment. We have one of our chairperson amongst us. We are waiting for the other two to join. Once they have joined, we'll continue with the session. Please, sorry for the delay.
Hello, Dr. Dave, can you hear me? Good morning.
Yes, sir. How are you?
Yeah, fine, very fine. I can see you also. It's
Yes.
just a test.
Yes, sir.
I'm testing just.
Yes. Nice, sir.
Can you see me also or not?
No, actually, yes. Yes, no. Your photo is not visible, sir. Your photo or video, whatever is there. Video is, I think, is.
Okay, I will check it.
Good afternoon, everyone. I welcome you all
Yes.
for the oral session on maternal, neonatal, and child health. We have amongst us our chairpersons for the day, Dr. Sanjeev Dave sir, who is a professor, Dr. Khurshid Musamil sir, I think there's some problem with the slide sharing mode. So we can continue with this only. So good afternoon, everyone. Today's the topic for the oral session is maternal, neonatal, and child health. And the first amongst us is Dr. Sanjeev Dave sir. And we have Dr. Khurshid Muzammil sir who has joined us. And sorry we couldn't connect with Dr. Shritesh Mishra sir. And I hope all the presenters have joined us. They can share their own screens and we can start with the presentations. First we have Dr. Karthika. Ma'am, can you please start sharing your screen and start with your presentation?
Sure, thank you, Dr. Nandita. Am I audible?
Yes, you are audible.
Yes.
Is screen visible?
Yes,
Yeah.
ma'am.
Respected chairpersons and my dear colleagues, a very warm good afternoon to one and all. I'm Dr. Karthika P, Junior Resident, Department of Community Medicine from Jawaharlal Nehru Medical College, Aligarh Muslim University. And today I'm going to present my paper on the topic Assessment of Menstrual Hygiene Management among Adolescent Girls of Aligarh, a qualitative study. Introduction. World Health Organization has defined adolescence as the period between 10 to 19 years of age. Adolescence constitutes 20% of Indian population. Menstruation is a significant event in adolescence. Despite being a normal biological phenomenon, it's a taboo topic across the world. Adolescent girls are often reluctant to seek information and follow the myths and misconceptions preached to them. The aims and objectives of my study was to assess the knowledge, water, sanitation and hygiene, and stigma associated with menstrual hygiene management among adolescent girls in Aligarh. A pretty number of studies have already been conducted on knowledge, attitude, practice related aspects of menstrual hygiene management. But to get to the root of the problem, one need to talk to the girls and understand what are their problems. Hence, I did a qualitative study under field practice areas under Department of Community Medicine, JNMCH AMU. Study duration was from January to March 2020. Anganwadi centers were randomly chosen from areas, and my study unit was an adolescent girl. The study plan was 4 focus group discussions were conducted among adolescent girls. Each group had adolescent girls who attained menarche, a facilitator, that's myself, posed the questions to the participants. A person to transcribe the data was present and the responses were recorded using mobile phones. The data that was recorded was later transcribed to local language and then translated to English and analyzed. The themes and sub-themes that emerged were analyzed using thematic analysis. And this is the FGD. I had 4 FGDs and a total number of 22 participants. And the age group of the participants, maximum were from 14 to 16 age group, that's number 12, and 17 to 19.7 and 10 to 13.3. And under the results, the major themes that emerged were general, knowledge, menarche, wash, and stigma. And the sub-themes that emerged were euphemism, under knowledge, lack of awareness of menstruation, the myths of menstruation, and under menarche, mother as a sub-theme, as 21 out of 22 participants told their mother at the onset of menarche. There was lack of awareness, pain, and apprehension associated with menarche. Under wash, procurement of matcha materials, availability of water and sanitation, and privacy. Under stigma, restrictions. Moving on to the results in further. Under general, euphemisms or the words used amongst girls for menstruation were periods, dates, mahina, MC, etc. Under menarche, 21 out of 22 participants told their mother at the onset of the menarche, which shows the importance of educating the mother as well as the adolescent girls regarding menstrual hygiene. All the girls had fear and apprehension of menstruation. अचानक से मुझे अजीब सा लगा जब ब्लीडिंग हुई थी, मेरे जो कपड़ा था उसमें आया था, which translates to all of a sudden I had a very bad feeling when the bleeding started. It stained my clothes. All participants were not aware about menstruation before menarche. 21 out of 22 participants mentioned that they felt weird or ajeeb sa. Everyone mentioned severe abdominal and back pain. Often they doesn't feel like doing anything due to pain. Then under knowledge, the children thought that bad blood was the cause of menstruation. हमारे शरीर में जो गंदगी जम जाती है वो सफाई करने के लिए है, which is translated to the bad blood that is accumulated in our body is cleansed due to menstruation. Kids acquired menstrual hygiene management materials from the shop. All the participants except 3 mentioned they had water and sanitation facilities to change their pads. 2 mentioned they had no washroom facilities at their home and had to go outside. 1 mentioned they are using neighbor's bathroom. हम तो बाहर जाते हैं, मतलब हम बाहर जाते हैं लैट्रिन के लिए, बाथरूम नहीं है हमारे यहाँ पे. A girl mentioned that they didn't have latrine at their house, so they had to go for open defecation. Under stigma, restrictions. Food restrictions included sour, imli, cold, rice, buttermilk, dahi, tablets were not allowed. They are not allowed in kitchen. They were not allowed to make the food, dug the floor. They were not allowed to play or do the household chores, do the pujas or touch the holy pitches. One girl even said that, "Hamare yahan to sab mana hai. Everything is restricted at my place." To conclude, there is severe lack of awareness among adolescent girls regarding menstruation. Any kind of intervention is required at adolescents and also at the level of women regarding menstruation. Wash facilities were available for majority of participants. Stigma and restrictions still prevail among the population. This is a photograph, references, and thank you. Thank you, sir.
Okay, sir. Now we can have any questions or queries you have. Our chairpersons have any queries to be asked. They can ask the presenter.
I think Dr. Sanjay Dave, he is mute. Can you help him?
Okay. Sanjay sir, can you please unmute yourself?
Okay. Yes.
My question
Am I audible now?
Yes, you are
Yes,
audible
sir.
now. My question to the presenter is that she has mentioned one thing, that the total population, adolescent total population is around 20%. May I know what is the source of this 20%?
So what?
Is the source from where you are quoting that the adolescent population is 20%?
Sir, from the WHO document, sir, I have mentioned it in my reference. 1 second, sir. World Health Organization, Adolescent Friendly Health Services and Agenda for Change, from this document, sir.
Okay.
I want to ask you what ways to GDs. Do we have any other way?
Voice is cutting off. Can you please repeat, sir, please?
When we do FGDs, like focus group decisions, do we have any other way to analyze them?
Yes, we do have. We can use statistical methods for analysis, sir. Sorry, softwares for analysis, sir. Sir?
Any of those quantitative softwares in your knowledge?
Hello? Hello, sir?
I think he's disconnected. Yes, Dr. Sanjeev, please unmute yourself.
Yes. I wanted to ask about that. What are the other ways by which we can analyze the FGDs? Apart, do we have any other way apart?
Yes, sir. We can make use of softwares like Atlas TI, and where we code the
Yes.
data that we have acquired, and then we can use it for analysis.
So what is your overall impression? So what is your one-word overall impression from your study? That the awareness is what you want to say finally, just in one sentence.
So I believe that the adolescent girls are lacking so much in part of knowledge. So some kind of intervention from school and from Anganwadi centers or from government schemes must be done so that they get to know about it.
Mm-hmm.
What recommendation you would like to give? What recommendation you would like to give?
Sir, inclusion of menstrual hygiene topic in school level, and like in government programs, inclusion of this menstrual hygiene management also, and providing sanitary napkins, etc.
You said
Yes.
that one of the participants.
Okay.
You said that one of the participant. He said that there is no toilet inside the house.
Yes, sir.
Have you cross-checked it?
Yes, sir. Yes, sir.
Is it possible? Because in such lots of campaign is going on about this availability of toilet in every house.
Yes, sir. Just one participant mentioned like that during my FGD.
You also found that there is no toilet inside.
No, so I didn't go to the house because it was conducted at an Anganwadi center. The participant mentioned like that, and I took it like that.
Okay. Okay. Thank you. Thank you.
Thank you, sir.
Thank you. Thank you.
Thank you, sir. Thank you, Dr. Nandita. Thank you all.
Thank you, Dr. Kartika. So now I think we can proceed with the next presenter. The next presenter for the day is Dr. Kiran Bala, and her title is Knowledge, Attitudes and Practices Regarding Tuberculosis Among Health Workers in Jammu. Over to you, ma'am, Dr. Kiran Bala, ma'am. Kindly start with the presentation.
Hello, good afternoon, everyone.
Yeah. Good afternoon.
Okay, let me share the screen first. Is the screen visible?
Yes.
Hello, is the screen visible?
Yes. Yes.
Okay.
Yes, ma'am.
Okay. Starting. Okay, good afternoon, everyone. So, topic of my study is knowledge, attitude, and practices regarding tuberculosis among healthcare workers in a rural hilly terrain in Jammu. So we all know tuberculosis is a major public health problem and is one of the leading causes of death in the developing nations. And if we talk about its incidence, 2/3 is contributed by 8 countries, and among them, India accounts for the maximum number of cases. Now, the success of National Tuberculosis Elimination Program relies upon the skills of grassroots level health workers who should be fully aware of all aspects of tuberculosis. Now, there are evidences which suggest that awareness and practice towards tuberculosis and its infection control is very poor in many primary and secondary healthcare facilities. So that's why there is, and as such, there is no published literature also. So that's why this study was planned in a remote hilly block of Jammu region. Now, coming to material and methodology, the study was of cross-sectional type, conducted for a period of 2 months in 8 primary health center and 1 community health center of Bilawal Tehsil, district Kathua, Jammu and Kashmir, after taking Institutional Ethical Commission IEC committee clearance. No, this district Bilawal is a hilly terrain which is located in district Kathua, having a population of about 1.5 lakh, and there are about 70 public health facilities, and we chose 8 primary health center and 1 community health center after briefing CMO and BMO of Kathua districts. No, in overall, 93 healthcare workers were interviewed face-to-face with the help of pre-tested semi-structured questionnaire, having both open and closed-ended questions covering socio-demographic information and knowledge, attitude, and practice questionnaires. The questions, now the knowledge and practice variables were scored, and if a healthcare worker give satisfactory response of more than 70% of questions, then that domain was considered to be good, and if it less than 70, it was considered to be unsatisfactory. Now, they were also just 2-3 lines about how we collect data. Data was collected with the help of this pre-tested semi-structured questionnaire by taking face-to-face interview, and healthcare workers were pre-informed with the help of BMOs, and they all reached at the PHCs and they were interviewed. Now, coming to results, a total of 93 healthcare workers were interviewed by us, and there were about 119 healthcare workers, but only 93 reported on that day, and the response rate was about 78.2%. Now, this is the first table showing the socio-demographic characteristic of the healthcare workers. And in this, we can see that females outnumbered the males among the category of healthcare workers. And there were about 80% of the healthcare workers, they were having experience of about less than 20 years. So this is a table showing the knowledge domain of knowledge domain, and it can be seen that only half of the healthcare workers, that is about 54.8%, they were aware of the proper symptoms of tuberculosis, and similarly 55% of the healthcare workers, they know how the TB, they know the mode of spread of tuberculosis, and majority of the healthcare workers believe that sputum can be tested to diagnose tuberculosis. And only 47 point, approximately nearly half of the healthcare workers they knew about that wearing a mask and following proper cough etiquette and isolating the helps in prevention of infection to other tuberculosis patients. This is a table showing attitudes of healthcare workers regarding tuberculosis. 91.4% of healthcare workers agreed that healthcare workers, they suffer from a higher risk, they have a higher risk of acquiring tuberculosis, and all of them, 100% believe that knowledge of healthcare workers should be continuously upgraded on recent advances in the field of tuberculosis. These attitudes were made using 5-point Likert scale, but for the sake of presentation, it was collapsed to agree, neutral, and disagree scale. This is the table 4 showing practices regarding tuberculosis. 90% of the healthcare workers observed that wearing a mask and staying at a distance from tuberculosis patients helps in contracting tuberculosis at the workplace. So in our study, the knowledge and this attitude and practices domain were found to be satisfactory in some areas and unsatisfactory in other areas, and we concluded it that the knowledge of healthcare workers should be refreshed from time to time with the help of continued medical activities, IEC and FGDs, so that the previous knowledge is updated. So we could not conduct any FGD in it, so this was a limitation. Of course, small sample size and time constraint and duration of 2 months were also its limitations. And we could not compare it with the healthcare workers or different cadres. But of course, in the hilly terrain area, such type of study is important, and we will come to know more and more about we will come to know that what are the shortcomings by which we can improve our program and reaching to the peripheral areas. Thank you.
Thank you. Khushi sir, you want to ask something?
Yeah, hello. I have one question here. Yes. Am I audible?
Yes, yes.
Yes, sir. Yes,
okay.
sir.
Okay. You said that the study tool, a study tool is the pre-tested semi-structured questionnaire, right? Why you are saying it is why you are saying it is semi-structured? The study tool, my question is, the study tool you said is pre-tested semi-structured questionnaire.
So it was semi-structured because when we reach at the field and whenever we feel that the patient is not the healthcare workers are not able to understanding it, we converted into in their way so that they can understand.
Which one was the first one? From where you have taken it and later on you redesigned it?
We have just reviewed the data and from different studies we have designed this questionnaire. It is not that we have taken it from a standard site, but from different studies we have taken this. We have designed this question.
Have you given this reference in your study?
Yes, sir. I have given this references. I have not made the slide, but I have given the references in my.
And one more thing, that you said that the knowledge, attitude, and practice was unsatisfactory in some domains, in some of the domains. What you will suggest so that it becomes satisfactory? Should I repeat my question?
Hello, am I audible?
Yes. Should I repeat?
Hello?
Should I repeat my question?
No, sir. You are saying that how the knowledge can be improved.
Yes, in those domains where you found it unsatisfactory.
So with IEC activities and I think better would be if we go for focus group discussions on that domains where they feel that where their knowledge was not good.
You mean more and more emphasis to be given for
yes,
this type of trainings? Huh?
Yes.
Whatever is right now is giving is inadequate.
Yes, sir.
So that means there is some fault in the program.
No, sir, I don't think that there is some fault in the program, but I think there is a fault in the perception of the healthcare workers, how they feel it. Like in our, many of them feel that it can be infected to the family members also. So there's a lot of stigma and other things attached to it. So the more we emphasize or on those points, it would be better.
Okay, thank you.
Doctor, I want to ask that why did you select only 8 PSCs and 1 CSC? Hello.
So we have to actually, sir, there was a time constraint in a 2-month period, and so that's why we chose only 8 primary health centers and 1 community health centers.
So is it what kind of can we label it as some kind of sampling method or something like that, or it's a what we can label this kind of study?
Actually, sir, it was a convenience sampling method. All those PHCs which were approachable, we chose them for the study purpose.
Suppose if you have to do a random sampling study with this random sampling, how can you plan such kind of study? Because this is a very important issue which is coming out from this. That knowledge inadequacy in some domains.
Yes, sir.
So, what do you think of? Suppose if you have got sufficient amount of time and all sorts of infrastructure and things are there. So would you like to extend this kind of studies, or how you can plan such kind of studies? Did you get that?
So we can, hello?
Yeah.
So please repeat the question.
Suppose if you have to carry out the study with a random sampling method, and so how you will carry out this kind of study in a community or something like that, with that, so that we can generalize that this problem is existing.
So we can have systematic random sampling where we can choose the more and more primary health centers.
Okay. So your conclusion is that some areas are deficient. They need to be corrected.
Yes, sir.
Okay. It's okay. Thank you.
So now we have our next presenter. Thank you, Dr. Kiran Bala ma'am. Now we have our next presenter, Dr. Swati Saraswat. She'll be speaking on the topic to study the menstrual hygiene practices among adolescent girls in urban area of Gwalior city. Over to you, Dr. Swati.
Yes, ma'am. I'm unable to share screen the share. Ma'am, I am unable to share screen.
तो यही सारे बोल रहे थे कि इसमें फायदा लेता जा रहा है क्या? हाँ, इस तरह पूछा ना। इतना नहीं पूछना। आपने स्टडी से रिलेटेड पूछा। हाँ, जनरल ये पढ़ लो।
Okay, ma'am. Okay, you are sharing. Okay, okay. Is it fine?
हाँ, नजमा।
May I request the coordinator to please
Yes, sir.
Please help them.
because background voice is coming.
Hello, Swati ma'am. Are you able to speak now? We can see your screen.
आपका वाइवा ले रहा था, मैंने स्क्रीन की अनम्यूट किया होगा, कैसे सालों के फिर सुन रहा होगा।
Ma'am, please start. Your time
Good
has
afternoon,
already
everyone. My study topic is to study the menstrual hygiene.
मैं हुई नहीं, आपने प्रेजेंटेशन म्यूट कर दिया।
Background voice is coming. Dr. Nandita.
Screen is
Yes, sir.
not visible now.
Everyone else, please mute your systems.
Yes,
I
ma'am.
request everyone else to mute your
Yes,
system.
ma'am. Yes, ma'am.
Yes, start, please.
To study the menstrual hygiene practices of adolescent girls in urban.
I think we have lost the connection with Dr. Swati. So can we wait? Huh? Dr. Swati, are you there? Sir, I suppose we should start with the next presenter. We can have Dr.
That
Swati.
can be done.
Okay. Then we'll have Dr. Ashutosh next. Over to you, Dr. Ashutosh.
Hello, ma'am. Can I share my screen?
So he'll be using my system
Hello.
to present presentation. So
Hello.
hello.
Hello, ma'am.
Good afternoon, respected chairpersons and remaining all. Am I audible, sir?
Yes, yes.
Okay, thank you, sir. So,
Yes, you are audible, Dr. Ashutosh.
yes, sir. So, shall I start, sir?
Please proceed.
Shall I start, sir?
Yes, proceed, please.
Okay.
Yes, you can.
So, I will be starting with my research title, that is Ascertainment of Causes of Neonatal Death Using Verbal Autopsy in Rishikesh, Uttarakhand, a cross-sectional study. And my outline of my presentation will be under these headings. So coming to the introduction part, so neonatal period, which is from birth to 28 days of life, which is a most critical time for survival of a child. And India is targeting to achieve neonatal mortality rate of 12 per 1,000 live birth by 2030. And reduction of neonatal mortality is possible only by understanding its causes. Then aim of my study was to ascertain the causes and time of neonatal death in Rishikesh, Uttarakhand, and objectives were to determine the causes and time of neonatal death using verbal autopsy in Rishikesh, and to identify and document point of delay contributing to neonatal death. Then material and methods. So it was a community-based cross-section study, and it was conducted in Rishikesh, Uttarakhand. And study duration was from for 1 year, and it was from July 2018 to June 2019. And the study participants were parents or any close informant of deceased neonate. And study tool I used was National Health Mission, Government of India Verbal Autopsy tool, and I included all the neonatal deaths which occurred between 2018, July 2018 to June 2019, and I excluded all those deaths which occurred after 28 days of life, or the participants who didn't give the consent. So I found total 23 neonatal deaths in my study, and I excluded one death. So because of parents didn't give consent, so total 22 neonatal death. For 22 neonatal death, I applied the verbal autopsy tool and get the data. So methodology was data extraction for the neonatal death in Rishikesh was planned from CMO office and Dehradun, as well as from Asha and ANM of Rishikesh. And after that, all the families and households of neonatal death from July 2018 to June 2019 were approached. Informed written consent was obtained after that, and verbal autopsy tool was administered, and data was entered into Excel and analyzed by using SPSS 23 version. And this is my result. So I found out of 22 neonatal death, perinatal asphyxia was the most common cause. That is seven deaths were due to perinatal asphyxia, and 6 were due to congenital malformation, 4 were due to prematurity, and 3 were due to neonatal sepsis, and 2 were due to sudden infant death syndrome. And out of total 22 neonatal death, in the second graph, we can see that most of the deaths, around total 15 deaths, occurred in early neonatal period, and among them total 5 deaths occurred within 24 hours, and remaining 10 deaths in between 1 to less than 7 days. And in the post neonatal late neonatal period, not post, and the late neonatal period, total 7 deaths occurred. And point to delay contributing to neonatal death. So here there were 3 delay model. So delay at the level 1 means decision making, delay in decision making to seek medical care. So total 9 deaths were contributed to this. And delay at level 3, that is delay at the facility. So total 5 deaths were due to that. And there were no delay. Total 6 delays were like that, in which there was no delay. And 2 deaths were like mixed type, like delay at the level 1 and 3, and delay at the level 1 and 2, that is facility and transport and decision making. In conclusion, so most major causes of neonatal deaths were perinatal asphyxia, congenital malformation, and prematurity, and most of the neonatal deaths occurred during early neonatal period. Delay in making decision to seek medical care contributed to most of the deaths, that is 9. And the strengths of my study were majority of interviews were conducted with the mothers, and they were illiterate, and causes of neonatal deaths were finalized by a neonatologist and a community physician. Limitations, less sample size and recall bias could be there. And recommendation, need to improve skilled care and strengthening of postnatal care services. And these were my references. Thank you, sir.
Thank you. Khurshid sir, you want to ask something? Hello.
Yes, sir.
I would request Dr. Khurshid sir to ask any question.
Yes, sir.
Yeah, Dr. Ashutosh.
Yes, sir. Yes, sir.
Okay. In your study area, have you taken the whole Rishikesh district or only the city only?
Sir, Rishikesh is a tehsil, sir, here in Dehradun district. Dehradun is a whole district. In Rishikesh is a tehsil, and I included whole Rishikesh. Here actually 2 parts are there, sir. One is rural and one is urban. So I included both of them, and whatever the deaths here occurred, I included them. And for that, I confirmed the deaths from the CMO office. From there, I collected the data, but I got only one death registered there. And I also for the death registration, I inquired from Nagar Nigam, where deaths were registration was not there, sir. So I tried to find out those deaths by asking the Asha and ANM, and simultaneously I did my study, sir. Wherever, so I inquired from all the Asha, sir, in Rishikesh.
You mean and the study period was for 1 year? In
Yes,
the whole
sir.
1 year, the total
Yes, sir.
number of neonatal deaths were only 22, 23?
23, sir.
Okay.
Yes, sir.
And you said in your conclusion, you said in your conclusion that all the deaths were confirmed by the neonatologist.
Yes, sir. Yes, sir. So after collecting the data by using verbal autopsy tool, it was in my methodology that I had to include two doctors. So one was a neonatologist, and one was a community physician. So I both the doctors, they separately analyze the data, and they comes into the conclusion, and they make their causes of neonatal death. And after that, I make the results, sir.
Okay. Okay. Thank you. Thank you.
Dr. Ashutosh, I want to ask that you have presented well.
Yes, sir.
Is there any program-related activity for neonatal death going on?
Yes, sir. Yes, sir.
So these kind of 20 deaths we have shown.
Yes, sir.
So is there any program which is running now for them?
Yes, sir. Actually, there is one. Yes, sir. One program is IMNCI program, then Naujat Shishu Suraksha Karyakram, then Janni Shishu Suraksha Karyakram is there. So, and these are the main programs, government programs are running to prevent the neonatal deaths.
What about INET? INET approaches?
Sir, actually, your voice is a little cracking, sir. Sir, what?
India Newborn Action Plan.
Yes, sir. Sir, it's a kind request, sir. Actually, your voice is completely cracking, sir. I'm not able to listen.
Okay. I want programmatic India Newborn Action Plan related activities to reduce these neonatal deaths. Is there any something like that which is there?
Indian Newborn Action Plan, sir?
Yeah.
Sir, may you repeat your questions? Sir, actually, your voice is completely cracking, sir.
Cracking. Okay. I want to know the impact of the Indian Newborn Action Plan in the district Rishikesh that you have found that 23 deaths.
Okay.
Whether the deaths are as per the norms, the deaths are as per the average numbers, or they are increasing or decreasing.
Sir, actually,
whether the program has got impact or not.
Yes, sir. Program is having impact, but not that much. That should be.
That is the
but
thing, yeah.
but if you will compare the neonatal deaths in last 5 years, as per the NFHS 4, neonatal death in whole Uttarakhand was, sir, 27, and and as per the SRS 2014 neonatal death in Dehradun, sir, it was 25. So compared to actually, sir, neonatal mortality data is lacking, sir. We are most of the SRS or NFHS data, they are commenting on infant mortality rate. So we are not having exact data of neonatal mortality, sir. But however, neonatal deaths are reducing nowadays because of good health facility in this area, especially, sir, in this zone. In Rishikesh, we are having 2 medical colleges, 1 sub-district hospital, and so many private hospitals are also there. So nowadays, because of improvement of this health facility, deaths are reducing, sir. But however, in my study, most of the deaths were due to the perinatal asphyxia, which most of the deaths occurred at the hospital level. So
Okay,
for that
Ashutosh,
also, sir.
Okay, Ashutosh, one last question to you.
Yes, sir. Yes, sir.
That which study tool you have used in your study? You mentioned.
Sir, it's a National Health Mission, Government of India verbal autopsy tool is already there, sir. So I
Okay.
use that tool.
Have you gone through the tool given by the RBI?
Sir, RB, sir,
RBI,
tool by RBI.
Registrar General of India.
Okay, no, sir. I
Okay.
don't have idea about that. I only.
Okay. Earlier, have you seen any similar studies conducted in Rishikesh or in this region?
Yes, sir. Actually, in Rishikesh, there was no study. Actually, it was my thesis title, sir. This was my thesis, so there was no study in Rishikesh.
Okay. Good. Thank you very much. Thank you.
Thank you. That's okay.
Thank you so much, sir.
Thank you. Third participant. I think we can proceed for the third part.
Yeah, Dr. Nandita, please invite the next speaker.
Next speaker, yeah.
Dr. Nandita, you there? The previous one. He is available. Give her a chance to present the previous one.
Dr. Swati can present.
Okay, she has come. Dr. Swati, you can start your presentation.
Yes, ma'am. Yes, sir. So shall I start, sir?
Yes. You can start now.
Shall I start, sir?
Yes.
Yes, sir. Yes, sir. So my presentation on to study the menstrual hygiene practices among adolescent girls. Introduction: menstruation is an important phenomenon by nature for women. It is a major stage in life.
Voice is not clear.
Female. Women undergo certain changes associated with reproduction, beginning from menarche till menopause. Stage of reproduction
Voice is not
includes
clear,
physical,
sir. Voice is not clear.
psychological.
Voice is not clear, Dr. Swati, please see.
I guess she's not
Voice
able
is
to
not
connect.
clear.
We can have the next presenter then. The next presenter is Dr. Priyanka.
Yes.
And her topic is unintentional injuries at household level among under 5 children in urban area of Faridkot. Dr. Priyanka, kindly share your presentation and start presenting.
Good afternoon, everyone.
Yes.
Good afternoon, everyone. Yeah, just a minute.
No, I am here. I am very much here.
क्या तो उधर सब है
हमें सबकी आवाज नहीं आ रही
Is the screen visible?
Yes, ma'am.
Hello.
Yes, ma'am.
Yeah, thank you so much. Good afternoon, everyone.
Screen is not coming.
Ma'am, please share your PPT. Your whole desktop screen is visible. Please.
No.
Presentation.
The screen is not.
Actually, I'm trying to share the screen.
Ma'am, can I present your presentation from here if you are unable to do so?
Yeah, please. Thank you. Please do it.
Okay, ma'am.
Is it visible now?
Yeah, it is visible.
Yes. Thank you, Dr. Nandita.
It's visible now.
Thank you. It's okay, Dr. Priyanka. Please kindly start presenting.
Good afternoon, everyone. I am Dr. Priyanka Singla, PG resident in Department of Community Medicine, Faridkot in Punjab. Today, I am here to present my oral presentation on unintentional injuries at household level and associated risk factors in under 5 children in Faridkot district. Introduction. Unintentional injuries are major causes of morbidity and mortality in children, resulting in over 630,000 deaths annually in children less than 15 years of age in 2011. Worldwide, Southeast Asia alone contributes to 31% of the burden of injury and 27% of injury-related mortality. In India, injuries are the fourth leading cause of death in children under 15 years of age. Next slide, please. Aims and objectives. To measure the burden of household level injury of under 5 children and identify major risk situations in or around home leading to injury proneness and to explore environmental risks, if any. Next slide, please. Materials and methods. It is a cross-sectional study of 115 mother-child duo of under 5 children in urban slums of Faridkot. House-to-house survey was conducted. Prepared list of households having under 5 children was consulted and randomly selected houses were visited. Informed written consent was taken from the caregiver before beginning of one-to-one interview. Next slide. The relevant information about demographic profile, unintentional injuries, various associated risk factors, house description for risk assessment and parental supervision was collected using semi-structured questionnaire. Next slide, please. So these were the results which we found. In this table, we show the distribution of injury according to socioeconomic class. In this table, what we can see is out of 115 subjects, majority, that is 60%, these are present in upper lower socioeconomic class, followed by lower middle, that includes 18.8%, upper middle, that includes 15%, upper, that includes 5%, and lower, that is 1.3%. This was not significant. Next slide, please. This table shows the distribution of injury according to house description. And in this table, what we can see is injury was present in 67% houses with enclosed courtyard, that is 83.8%, and then 68.8% houses with separate kitchen, 100% houses with bathroom within house or courtyard, 100% houses with toilet, 33.8% houses with balcony, and 70% houses with stairs, 98.8% houses with less than or equal to 2 floors, and 1.3% houses with greater than or equal to greater than 2 floors, and then 83.8% houses were owned by the owners, and then 60.3% were rented houses. 25% houses with less than 10 years old, and 75% houses with more than 10 years old. And 66.3% houses, they had less than or equal to 3 separate rooms, and 33.8% houses had more than 3 separate rooms. In this, the significant factor which came out to be, it was only the age of the house. This, and then please the next, and rest were not that much significant. And the next table, please. Dr. Nandita. Yeah, thank you. This table depicts the distribution of severity of injury according to presence of caregiver. And in this injury pattern which is visible is mild injuries present in 100% houses. Moderate injury in it's also present in 100% houses with presence of caregiver. And then severe injuries also present in 100% houses, that is one house in the presence of caregiver. So in these tables, what we have seen the presence of injury with respect to various variables. And this also came out to be significant. Next slide, please. Discussion. In our study, majority, that is 60% injuries were in upper lower socioeconomic status class, which was in concordance with Bhuvneshwari B. et al. That showed an inverse association between socioeconomic status and injury. Next slide, please. And a study conducted by Sharif et al. Showed higher proportion of unintentional injuries among children left alone. While in our study, the presence of caregiver is directly proportional to presence of injury, which may be attributed to lack of knowledge and awareness of mothers regarding unintentional injuries. So what we can conclude from this study is, the present study concludes that the unintentional injuries are among major causes of morbidity in under 5 children, that too among preventable causes. Most of the children who land up in severe type of unintentional injuries carry some form of deformity or disability for whole of their lifespan. That makes it significant. Thank you.
Thank you. Sir, you want to ask? Dr. Ushi, sir?
One question. Dr.
Yes,
Priyanka,
sir. Yes, sir.
in the conclusion, you said that 60% of the injuries were seen in the upper lower class, right?
Yes, sir.
Why this majority is in the upper lower class? What could be the reason for this?
Because most of the houses are in the field were upper lower. Hello.
Sorry, can you repeat?
Sir, most of the houses, they were in those categories. So in concordance with the number of houses in that class in my field practice area, actually that was in concordance with that thing, that most of the houses in upper lower class in that area, in my study area.
Okay.
Thank you, sir.
Okay. So what mothers need? What kind of education we need to give mothers now? Can we have some specific instructions to the mothers and how to prevent these kind of unintentional injuries?
Yes, sir. We can give them education regarding the risk factors. We have prepared home injury hazard checklist for that thing, so that mothers can take care of those factors at least in their home. At least those factors can be prevented. Like for drowning, we can say open containers of waters or liquids such as bucket, drum, etc. should not be placed. And holder vats for feeding kettles should be covered. And sir, just for fall injuries, we can say bathing area should be free from slippery surface. All windows should be secured with window guards. Walking areas should be clear of clutter, like telephone or electrical cords, etc. And large objects like bookshelves, TVs, other entertainment units, any furniture, they should be stable on their own or secured to the walls. And surface of chairs, balconies, porches, they should have non-slip surfaces. Or we can keep them free from any liquids, or water, or any greased material. Then protective handrails should be installed on the both sides of the ladder.
Okay, that is okay.
Sir, I'm not able to interpret what are you saying.
Okay, that is okay.
Connection is breaking. Hello. Sir, I'm not able to hear.
Okay. I want to know how did Hello.
Sir, I'm not able to hear you properly.
Dr. Sanjay sir, can you please type your question, because we are not able to hear you. Your voice is breaking. Maybe there's a connectivity issue. Or we can proceed with the next presenter, because we are already running short of time.
Okay. We can proceed with nothing like that. Okay. It's not we are already running short of time, so we can proceed for the next one.
Okay, next we have Dr. Najma Akhtar. She'll be presenting on the topic, a CAP study addressing iron-rich nutrition and iron deficiency anemia among women aged 14 to 49 years. Over to you, ma'am, Dr. Najma Akhtar.
Good afternoon, everyone. The research I'm going to present today is awareness regarding iron deficiency anemia among females of reproductive age group, that is 15 to 49, living in Jammu district, a cross-sectional study. Well, as we know that iron deficiency anemia is one of the most common nutritional deficiency, and nutritional requirement of iron is as compared to males is more in female, and it is optimal especially during reproductive age. And awareness regarding iron deficiency anemia and its prevention can serve as an important tool for curbing this nutrition deficiency, and can also help in improving the general health status of this population. So with this background, the objective of our study was to assess awareness regarding iron deficiency anemia among females of reproductive age group living in district Jammu. Well, the study designed for this was cross-sectional study, and we have conducted this study at Trakuta Nagar and Kirpind village of Araspura, which are the field practice area of GMC Jammu. And the respondent in this study were 448 females, and we have used a convenience sampling for this study. And for this study, we had taken ethical clearance from Institutional Ethical Board of GMC Jammu, and we have done this study as
Hello.
The voice is not coming.
Voice is not coming.
hello.
Yes.
Hello, sir. I'm
Yes.
sorry. Basically, we have having mutation. Connectivity issue here. Sorry. Okay, we have taken for this
Voice is speaking now.
pre-designed.
Yes, proceed. madam.
Sir, is it audible now?
Yes, please.
Sir, it is audible now. Yeah.
Yes.
For this study, we have used a
Yes,
pre-designed
yes.
questionnaire which was adopted. Sir, am I audible?
Yes.
Hello.
Yes, ma'am, you are audible.
Okay.
Please
For
continue.
this study, we have used the guidelines for assessing nutrition-related knowledge, attitude, and practices, guidelines, which we have taken the questionnaire from this FAO guidelines, and we have modified it according little bit to fit in our community settings. So, as far the result is concerned, in our study, 87% of women reported that they have heard about the symptoms of, about anemia, and among the symptoms, most common symptom reported, which was reported by around more than 80%, was pale face and fatigue, and 9% women even reported breathlessness as symptom of anemia. And among the causes of anemia, the most common cause which was reported was lack of adequate amount of diet. And low birth weight baby and weak baby was reported as the most common consequences of anemia in pregnancy. So about the ways to prevent anemia, most of the women reported that basically reported iron-rich foods like pomegranate and chanas, green chanas. They reported like iron-rich food as in most in 50%, more than 50% reported that consuming iron-rich food can actually prevent anemia. And as per the food that help in absorption of the iron, about 30%, 4% reported that vitamin C, like nimbu, adding nimbu to the food can increase the absorption of iron. And surprisingly, 11% reported that taking dessert after meals can help in absorption of iron. And tea, coffee was reported by 30% as inhibitor of iron absorption. Among the iron-rich foods, non-veg food was reported as was the most common food which was reported as iron-rich food. And chicken, among the non-veg items, chicken was reported the most common non-veg food item. And among the fruits, pomegranate followed by apple and guava was reported as the iron-rich fruits, and spinach was reported as the most common green leafy vegetable, which is iron-rich. And conclusion is that as awareness regarding the iron deficiency anemia was found to be satisfactory for most of the questions. However, still there is large scope of counseling and health education for improving and enhancing the quality of these women. Thank you so much.
Yeah, can I ask one question?
Yes, sir.
Yeah, madam, you said that the knowledge or awareness about this iron rich food items and everything related with the iron rich items is very good among the participants, right?
Yes, our results suggest so.
So, and again, in the suggestion, you are saying that there is a lots of scope for further, health education and other things. You are saying something. It is already very good.
So basically, some of the food. Sir, the knowledge was found to be very good, but we were thinking that the foods that we can impart more knowledge about the food, various food, other options which are available, like they are able to give us few items. So in our diet, there are so many things that can actually help in increasing their iron absorption. So since no one of the participant was not able, they were only telling us chicken, while as compared to chicken, meat is having high absorption, and fish is also having over 70% of the fish protein and substance can be absorbed by the body more palatable as.
Okay, thank you. Thank you.
So we can lastly try again with Dr. Swati. Dr. Swati, are you ready?
Yes, ma'am, I'm ready.
Okay, I'll share it.
Hello.
Hello. Yes, your screen is visible.
Yes, ma'am. My presentation on to study the menstrual hygiene practices among adolescent girls in urban area of Gwalior city, a cross-section study. Menstruation is an important phenomenon by nature for women. It is a major state in life of female. Women undergoes a certain changes is associated with reproduction beginning from menarche till menopause. Adolescence is the stage of reproductive development. It includes physical, psychological, and social development occurring from puberty onset to adulthood. Menstruation deals with hygiene deals with special healthcare needs and requirements of women during menstruation. Methodology: it is a community-based cross-section study which is carried out in Vayanagar area of Gwalior city. The study was undertaken 250 adolescent girls between the age of 10 to 19 years of age. This study was carried out in a period of 3 months, that is 1st November 2019 to 31st January 2020. The sample size was calculated using the formula 4 pq L square, where prevalence of unhygienic practices is 48.75, which is according to a study conducted by Sodeshna et al. In Kolkata. The sample size is 100. Pre-formed and pre-tested questionnaires was used to collect data consisting of questions regarding socio-demography, awareness about menstruation and its pattern, and necessary hygiene required during and post menses. A prior consent and assent taken before interview. Results. Table 1 shows that 69%. Table 1 shows the distribution of study population according to socio-demographic factors. 69% patient participants belong to late adolescent group, that is 15 to 19 years of age, and 92.4% participants were Hindus and 70.8% participants were part of nuclear family. Table 2 shows the education-wise distribution, which shows maximum 46.8% were up to intermediate, that is 11 to 12 standard. Majority of also 10.4% of the participants were school dropouts. Majority of participants mother 30.8% were illiterate, and participants father 30.8% were educated up to higher secondary school. The proportion of postgraduate fathers, that is 11.2%, was higher than mother, that is 6.8%. Table 3, which shows the occupation wise distribution. Majority of fathers, that is 62.8%, while just a few mothers, 4.4%, had skilled occupation, and 22.3% of fathers and 20.4% mothers had semi-skilled occupation, and 14% fathers and majority of mothers, that is 75.2%, had unskilled occupation. Table 4, which shows the pattern of menstruation among um, among population, which shows that 31.6% patients had menarche at age 13 years of age, and 83.2% had regular menses, whereas 16.8% were irregular. Majority 68% had moderate blood flow. The duration of blood flow was observed to be between 4 to 6 days in majority, 59.2% of the participants. And table 5 shows the awareness about menstruation. Majority of the participant, 57.6%, were aware of menstruation before menarche, and majority of the participant, that is 63.6%, knew the source organ of bleeding as uterus. More than half of the patient participant, that is 50.8, knew that menses is physiological. And table 6 shows the practices of menstrual hygiene. It shows that 81% washed the same cloth and reused it for more than 3 times. That is, 82.4% girls changed the pad frequently at more than 3 times a day. And sanitary pads were wrapped in paper and disposed by 69.7% of the participants, and 97.2% of the participants practiced hand washing during menses. They used soap and water in majority during menses. Here is the discussion. Deshna et al., the study conducted in Kolkata, which shows that 57% were 15 to 19 years of age, which is also similar in my study, and Omidwar et al., in which 90.2% Hindus and 70.26% nuclear family, which is also similar in my family, and Thackeray et al. This is contradictory to my family study, which shows 7.49% mothers were illiterate. But in my study, there are 30.8% of the mothers were illiterate. This wide difference was because this study was carried out in mixed population. And in Sharma et al., the mean age is 20.8 years, which is also similar in my study, which is 13.39 years. In Vasnik et al., 78.2% had regular menstrual cycles, which is also my similar Sharma et al., in which dysmenorrhea 61%. In my studies, 57.2% experienced dysmenorrhea. In Prajapati et al., 17% girls could identify uterus as the origin of bleeding. In my study, 63.6% of the participants knew the source of the menstrual bleeding, and this proportion is quite high as compared to the research done by Prajapati et al. In my conclusion, menstruation is an important indicator of reproductive health and development. Menstrual hygiene practices are a major concern. Menstrual hygiene among adolescents needs improvement. Hygiene is closely related to the education level. Improper assumptions about menstruation need reversal. Educate about menstrual physiology, concepts, and needs to the girls is necessary. Thank you.
Thank you very much. Dr. Swati, just one question I want to ask from you.
Yes.
Yeah, you mentioned about the classification of the adolescent age group. That is from 10 to 14 and 15 to 19. Early is 10 to 14 and then 15 to 19. From where you got this classification?
Sir, it is classified by me only. So to divide the population into 2 groups.
Okay. Actually, generally, what we which is in practice is we divide it like early, middle, and late, right?
Yes, sir.
One of the presenter, she has also presented like that only, the early, middle, and late. The early includes 10 to 13, middle is 14 to 15, or 14 to 16 sometimes. 17 to 19 is the late one. Okay.
Yes, sir.
So you cannot design your own classification, but one should have a proper reference for that. This is my just advice for you, because you are doing your study. You have presented very nicely. Thank you very much.
Thank you, sir. Thank you so much, sir.
I have no question. Okay.
Yes.
Thank you so much.
Thank you, sir.
Thank you.
Dr. Najma. And I would like to thank our chairpersons, Dr. Sanjeev Dave sir, Dr. Khurshid Muzammil sir, who could spare so much of their valuable time for our session. Thank you so much, sir. So now I request you to kindly please fill up the Google form link, which I have already sent the link to you.
Okay.
For the prize distribution. Thank you so much, everybody. Thank you all.
Thank you. Thank you.
Now we'll
Thank you,
proceed to the
sir.
next session.
Thank you,
Thank you,
and thank you,
sir.
Dr.
Thank you.
Thank you, Dr. Nandita,
Thank you,
for
sir.
Sir,
providing
we
the space.
took already a lot of time, so thank you so much for your
Thank you
valuable
for
time.
providing the platform, and I could meet my ex-friend, Dr. Sanjeev Dave also.
Yes,
Sir, I could also meet. Yes. Thank you, sir. Thank you.
sir, Dr.
Thank you.
Pradeep also wanted to meet you. Sir, please wait. He will just join.
Yeah, Dr. Pradeep, please come.
Yes, sir. Yes, sir.
He's looking very smart today. Dr. Pradeep is
Hello,
looking very
sir.
smart. Yeah, you're looking
Hello,
very
sir. Hello. How are you? Fine.
Yes.
Thank you, sir. Thank you. Thank you very much. Thank you for joining
Thank you,
us.
sir. Thank you.
Yeah.
Thank you.
Thank you. Sir.
Thank
Thank
you.
Thank you so much, sir. Now I'll request the other speaker to kindly conduct the start with the next session. Thank you so much, sir.
Thank
Can we
you.
leave now, Dr. Nandita? Can we leave
Yes,
now?
sir.
Okay.
Yes, sir. You can leave now.
Okay. Thank you so much.
Thank you so much, sir. Thank you so much. Thank you, the presenters. You can join the next session also, or if you would like to join another session in another hall, you can do that also. Various sessions are going on. Thank you so much for your valuable time and your presentations.
A very warm good afternoon to everyone present here. So we will start with the next session, that is the evidence-based public health, and the I will share the screen. Wait a minute. Okay, so these are the various speakers of today. Dr. Balbir Singh Deswal, Professor, Dr. Anurag Shrivastava, and Dr. Sona Maheshwari. Okay, so we will start with the first session. Now I would request Banipreet Kaur to start with her presentation, please. Is Ms. Banipreet here?
Hello. Yes, I am here. Can I share my screen?
Yes, sir, you can.
You will have to. Thank you.
The time allotted will be.
Ma'am, we are time bound. Please, you have 5 minutes for your presentation and for discussion round. So please adhere to the timeline. Ma'am, you can start. Thank you, ma'am.
Good afternoon, everyone. I am Banipreet Kaur, intern in Maulana Azad Medical College and Lok Nayak Hospital, New Delhi. The topic of our study is the quality of life of Indian healthcare workers during COVID-19 pandemic. There has been a major concern about the quality of life of healthcare workers as frontline warriors with extensive and unpredictable spread of COVID-19. Factors affecting the overall well-being of healthcare workers are poor working condition, prolonged work duration, stigma and discrimination in the community, high risk of infection. This survey was conducted to understand the quality of life and its key determinants among the healthcare workers during the COVID-19 pandemic in Delhi. 302 healthcare workers participated from Lok Nayak Hospital and Guru Tegh Bahadur Hospital, tertiary care COVID dedicated hospitals of Delhi during the months of June and July 2020. Instruments used were short form health survey SF36 questionnaire and self-designed questionnaire which intends to measure the demographics of healthcare workers, extent and type of involvement of COVID-19 pandemic control, level of exposure, etc. Google form-based online questionnaire was circulated and all the participants who were working directly or indirectly in the patient care were included after taking an informed consent. The results are 59.3% of the participants were males and 41.7% were females. 81% belonged to the age group of 21 to 30. 84% of the participants were from the clinical specialty and 9% from the paraclinical specialty. These pie charts here show the level of exposure of healthcare workers. The first one shows the number of hours of COVID-19 affected patients seen per week. 43% of them have seen more than 30 patients per week. The second one shows the place of work. 95% of the healthcare workers worked in wards and ICUs, whereas only 5% worked in laboratories and testing centers. The third graph shows the number of hours devoted to COVID-19 duty per week. Here again, major percentage, that is 53%, work for more than 48 hours in a week. The last one shows the nature of job where 89% worked in red zone. The next variable here is personal protective equipment. Here we have shown the level of comfort, availability, and quality of PPE. While majority voted for good quality PPE, that is 83%, and 90% voted that the PPE was available, 55% of the population found it to be uncomfortable. Here we have looked at the satisfaction levels of working conditions and other facilities like food, transport, accommodation. The first one, 78.8% shows that the working conditions were satisfactory. 73.15% were satisfied with meals. 91.1% were satisfied with accommodation facilities, but only 60.1% were satisfied with the transport facilities available. Here, the first one shows the factors other than their routine COVID-19 hospital duty, which may have had an impact on their quality of life, which include social isolation, lockdown restraints, financial concerns, parental concerns. Majority voted for social isolation and lockdown restraints, that is 69.9% and 57.9% respectively. These two graphs show the relation between fear of getting infected with specialty and nature of job. Here, greater percentage of healthcare workers from the preclinical department showed greater fear of getting infected compared to those from the clinical specialty. The second one shows that greater percentage of those working in the green zone showed fear of getting infected than those working in the red zone. These show the SF36 form results. Poor quality of life was noticed across all the 8 domains of SF36. However, poorer scores obtained for domains measuring mental health with the median value of 64, vitality 55, social functioning 62.5, emotional health 50. To conclude, in the study, major percentage of the participants belong to 21 to 30-year age group compared to another study done by Maria Saridi et al., where the average age was 44. The major contributing factors for stress were social isolation and lockdown restraints. Fear of getting infected was seen more in those working in green zone and those from preclinical disciplines. Comfort level of PP was also concerning factor of quality of life, as 55% voted that the PPE was uncomfortable. Literature review revealed that the appropriate PPE remains of paramount importance to help physicians feel physically safe. 18.2% of the healthcare workers found the administrative staff to be not supportive. The scores of various domains of SF36 do not vary across age, gender, specialty, and place of work. The implications: healthcare workers are critical resources in managing the pandemic. The results of the study will be important from policy perspective as well as in managing them efficiently in course of current pandemic in India. Findings of the study are critical in framing management protocol of health workers during outbreaks and health emergencies. Thank you.
Hello, Dr. Vani.
Yes.
Am I audible?
Yes, yes, you are.
Yes, please, you have presented very nicely. Please, I want to know how do you find your sample size? 302.
Ma'am, actually, we had sent our Google form to around 700 to 800 candidates from Lok Nayak Hospital and Guru Tegh Bahadur Hospital, out of which 302 responded to our study, and we have the results.
Okay. I would suggest please calculate sample size using appropriate formula. Then it will be better for your study.
Sorry, ma'am, can you repeat, please?
Yes, I would suggest
Dr.
that
Banipreet?
Yes, yes.
Hello.
Hello, yes, sir.
And Dr. Banipreet, am I audible?
Yes, 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 sir.
I have two suggestions for you.
Yes, sir.
Whether this SF36 is suitable for your study, and the another is if it is suitable for the study, then better to confine on the finding of SF36. You got my query?
Sir, are you suggesting that SF36 is suitable or not?
Yeah.
So actually, the well-being of a person involves not only physical but mental, emotional, social, all aspects. SF36 form has 8 components which cover all the aspects of overall well-being. So we decided to have two questionnaire. The first one would be a questionnaire which would be self-designed, which
Dr.
covers all.
Banipreet, there is no need to explain all these. Only the suggestion is that first it is better to check, and the other thing is it is good for all of us to present the findings of SF36 in your presentation. I think it is a part of a certain project. Only certain findings are presenting here. That's why the problem is there.
Okay, sir. So I have in my slide I have shared the results of SF36 where I have calculated the median value of all the components for all the 302 healthcare workers.
Okay, thank you, Dr. Bani.
Yes, sir. So shall I share the results again?
Thank you, Doctor.
Hello.
Thank you, Dr. Kaur. From my
Thank you,
side,
sir.
it's over.
Okay, thank you, sir.
Hello, good afternoon. I'm Dr. Arpita. Shall I start presenting?
Yeah, sure. Please continue.
Okay, someone else has started screen share. Do I have to present or Dr. Nausheen is presenting?
Please, Dr. Arpita, you present.
Okay, all right. Just give me a moment to share my screen. Is the screen visible?
Yeah.
Okay. Good afternoon, chairpersons, and thank you organizers for giving us this platform to present one of our researches by NCC VMRC. I'm Dr. Arpita Gupta, working as technical officer at NCC VMRC, which is the National Cold Chain and Vaccine Management Resource Center, NIHFW, in New Delhi. So what we did was, to give you a background, under Universal Immunization Program, we at our center manage the immunization supply chain related activities for the country. And for capacity building of human resources involved in immunization program, we have developed a course called the TVAC course, that is Training on Vaccine and Cold Chain Management, with which we help to improve the skills and knowledge of immunization program managers at national, state, and district levels. This was a physical course usually conducted for 5 days, full days, but due to ongoing COVID-19 pandemic, we had to quickly adapt to the situation, and to continue the capacity building, we converted this course into a virtual one, which with the first virtual course conducted in October 2020. But at the same time, it was very important for us to understand the key challenges, as well as to understand whether this type of methodology is feasible to train the human resource from national to state to district and so on in a cascade fashion, and if it is sustainable or not. With this objective, we formulated a study to assess the acceptability, feasibility of this course, to identify the key challenges not only by the participants, but also faced by the trainers during the training, and to assess this effectiveness of the course by assessing change in the core competency, that is change in the technical knowledge of the participants, and on that give recommendations. So what we did in our methodology was that we collected the data using a TVAC app, which is a specially designed app by NCC VMRC on our website portal, specially designed for this training course. And we embedded all the questionnaires within this portal. We had participants, around 24 participants from 6 different states, which were chosen strategically, and 13 trainers who had been trained previously at national level were chosen to facilitate the course. So we collected data at 3 points of time. Before the training, we collected general information of the participants, took their informed consent, and administered them a questionnaire to assess their core competency, which we call the pre-test. It consisted of 20 questions, each question related to the technical knowledge related to vaccine and cold chain management. During the training, we tried to capture the process of the training, how it must have impacted the course. And we also listed down the key challenges faced by the participants and the trainers. At the end of the training, we again administered the same questionnaire to assess the core competency, the post-test. And to assess the acceptability, feasibility, we used a specially validated tool, which is called the music model of inventory, which helps us to assess these measures, these factors. We also took an open-ended feedback from trainers and participants on how could we improve upon the various aspects of this course. As you can see, we had 23 trainees. This was because we started initially with 24, but one of them dropped in between due to some family emergency, and only 23 were able to complete all the modules of the course. We made around 20 calls to them, and they also made similar calls to us on emails and on direct mobile numbers to resolve their queries and for technical assistance. As you can see that 18 were male and 5 participants were females, and 4 of them were from state level and 19 were from district level officers. The mean age of the participants was 49.7, and of that of the trainers were 38.7 years. Most of them used a laptop or a desktop for undergoing the training, and almost 70% had a previous experience of virtual training in immunization section. As we can see, the change in core competency, the mean scores increased from 11.3 to 13.3, which was a 2-point significant change. On applying t-test, we found this value significant with a p-value of less than 0.001. When we studied the key challenges which were faced by the participants and trainers, we grouped them into various domains. Some were internet related, as are bound to happen. Some were the platform related, that they were getting logged out again and again. Sometimes the video quiz or the apps, the polls were not opening up, or some course navigation related. Sometimes participants also said, since they were attending these trainings while being in office, they had other competitive work priorities also, and due to which they had to miss out either part of some sessions or some sessions, and they were unable to pay full attention as they had joined virtually, and simultaneously they also were sitting on their desk, and these are state officers and district level officers, so they're always overburdened with a lot of work. And trainers also said that they had some time management issues, as they were not able to resolve all the queries from the participants due to time constraint as allotted in the session. This is a snapshot of the acceptability and feasibility course. This is a tool of 26 questions, which are grouped together to be labeled into the categories of this. And each category had maximum score of 6. As you can see, in acceptability, appropriateness, adoption, feasibility, the participants' mean grading was above 5. So we can see that out of 6, if we achieved 5, that training was indicated that the training is favorable. Similarly, other studies have shown by Maulik et al. In 2017 that the pre-post evaluation, the mean score had improved by 1.5. We found that in our study it improved by 2. Vikram Patel et al. In 2020 found out in one of their studies using the music tool inventory that the acceptability and feasibility of online courses was around 5. We found that in most of the categories it was 5.4 or 5.6, which is showing that it is quite acceptable and quite feasible. Similarly, by Harris PA et al. In 2019, they said that software transfer is the tomorrow for the line of community health workers in our field. For the conclusions and recommendations, we found that the course virtual training methodology was very effective to improve the knowledge, as well as was feasible, acceptable, and this is the best possible solution in the current pandemic that we are undergoing for continued capacity building of the workforce. We found that to remove most of the key challenges, what we can ensure is that these program managers are relieved from their regular administrative duties, and they are solely dedicated their time for the training, so that they are not disturbed by other routine work. We can continue to resolve their queries through specially developed email forums, or we can maybe alter the session structure in a way that they have more time for interaction and less time for session presentation. And given the advantages of the virtual training methodology, it saves cost programmatically, and it prevents travel time, and it helps people to join from several states together, and it is feasible to conduct even for the trainers. Given all these, maybe in a blended form, this methodology is sustainable for immunization program capacity building even after the pandemic is over. These are some of the references that we used in our study. Thank you so much. I'm open for questions from the chairpersons. Am I audible? Do I have any questions, sir? Ma'am?
No question. Thank you.
Thank you so much, sir.
जिम इसको नीचे उतारना।
Sir, shall we start?
हेलो 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 हेलो
Hello, Dr. Navsheen.
हेलो shall I start?
Yes, please.
I am Dr. Navsheen. I have done MD Hospital Administration. I will be presenting a study on workplace violence against healthcare workers in emergency department of a tertiary care institute. Violence against medical personnel is unexpected in hospitals which are devoted to healing, and yet it is frequent and of concern in health system. The World Health Organization defines workplace violence as the incidents where staff were abused, threatened, or assaulted in the circumstances related to their work. The healthcare professionals accounted for 1.2% of the workplace homicide victims in US, and about 4.9 to 65% of the healthcare professionals were physically injured in their workplaces during an incident of workplace physical violence. When someone experiences workplace violence, it can impair their job performance, decrease productivity, and cause them to make more errors. Methodology: a cross-sectional study was conducted in the Accident Emergency Department of a Tertiary Care Hospital of North India from 1st of March 2019 to 31st of May 2019. A validated questionnaire was distributed among the staff, including the doctors and the paramedics. The response time was fixed for about 2 weeks, and those who did not return the performer were excluded from the study. A total sample size of about 130 healthcare workers was included, which included 42 doctors and 88 paramedics. Among the doctors, 2 did not return the questionnaire and were excluded from the study, and 14 paramedics did not return the questionnaire and were excluded for the study. And as such, 114 healthcare workers were included in my study. The majority of the persons included in the study were of the age group of about 30 to 50 years, that is 57%. And the majority of the healthcare workers included in the study were from rural areas, that is 59.7%. Majority of the healthcare workers were males, that were females, that is 74%. A total of 86 healthcare workers among the 140 included in the study reported some sort of workplace violence, thus accounting to about 75.4% of the healthcare workers who faced the violence. Experience was a significant factor associated with the healthcare workers. Those with having the experience of about more than 10 years showed less experience of workplace violence, with a significant p-value of about 0.01. Relating to the time, the workplace violence was found more in the evening hours, that is 64.9%, and with a significant p-value of less than 0.01. With respect to the specialty, workplace violence was seen more from the medical side than the surgical side. Majority of the healthcare workers experienced one episode of workplace violence, that is 79%, and 20.9% showed more than one episode of workplace violence. Relating the type of violence, 50% reported non-physical violences, whereas 30% showed physical violences and 21% showed both physical and non-physical violences. The perpetrators of the violence were majority the attendants, that is 71%, followed by the visitors, that is 19%, and the patient himself was a cause of violence in about 10%. The consequence of violence was majority, that is 79% of the healthcare workers complained of headache, followed by the decreased job satisfaction, and 62% were scared, whereas 66% showed that there was loss of sleep. Thank you so much. Hello? Yes, please.
Hello.
Hello.
Thank you, Dr. Navsheen. Next, please.
Thank you. Hello.
Hello. Hello.
Hello. Hello.
Hello. Am I audible, Dr. Navsheen?
Yes, ma'am. Yes, ma'am.
You have presented very well.
Thank you, ma'am.
Thank you. Now, please, next participant, move on.
Sharon, I have one question for that.
Yes, sir. Yes, sir.
Dr. Noshin, you categorize the violence in the physical and non-physical.
Yes, sir.
I just have a query about that operational definition taken for physical, non-physical, and combination of both.
So actually, the physical violence I categorized where it was actually with the what WHO defines physical violence and how we define the non-physical violence. In a non-physical violence, it is just the verbal abuse. In the physical violence, it is the use of hands in either form. Either it's the use of any body part, either which hurts a person as such. And both is like where the healthcare workers has experienced both the physical and the non-physical violence.
Dr. Noshina, a bit confused I am, as how is it possible to do a physical violence without involvement of a non-physical violence? It's a phasic manner in the sense of practical in a practical way. It is usually seen that it is first it is non-physical, and then in the extent of or the emotional intense, it has become converted into physical.
True. So agree, sir. So actually, when the questionnaire was distributed, the 30% of the people who complained only of the physical violence were the healthcare workers who were associated with the others. Actually, when there was an event of violence, there is not only one healthcare worker who was involved in it. It is like by chance the other person got a kick, by chance the other person got a slap. It was like that. They experience a physical violence. As such, as you rightly said, when there is healthcare violence 101, it is both physical and non-physical, or it is only non-physical. But the associated healthcare workers who are around, they by chance get some sort of involvement into it, and it is regarding that.
Okay, thank you, Dr. Noshi.
Thank you so much. Thank you so much, sir. So, any question more? So, any more question, please?
Thank you, Dr. Noshin. It's over.
Thank you. Thank you so much. Thank you.
I think there is some problem with the network, and so can we move on to the next presentation by Dr. Swapnil Tanaji Sangre on an online study to assess the disposal of personal protective equipment at home amid COVID-19 pandemic.
The next presentation, please.
Yes, sir, I'm trying to share the screen. Actually, there's some problem, I think, from my part. I'll just start.
Okay, take your time, please.
Is my to everyone? Hello? Is the screen visible to everyone? Hello, is my screen visible to everyone?
Yes, Dr. Amandeep, carry on.
Sir. Thank you, sir. I am Dr. Amandeep Kaur, an assistant professor in All India Institute of Medical Sciences, Kalyani, and I'll be presenting a part of the study we conducted on the pattern of workplace violence faced by doctors. It was a nationwide survey, cross-sectional study, and I'm going to present here some of the descriptive findings. Now, so as Madam in the previous presentation has already said that violence against doctors is on, and they are on an increasing trend. And even if you know that even during this COVID era, we are not being spared. The incidence of violence against doctors has come into notice in almost every sector, in almost every part of the country. And as the evidence against what is the actual pace of violence, what are the types of violence faced by us, and what is the frequency is really very less. And the nationwide data, especially collect from that are representing the doctors from private sector and public sector both, and also from the rural areas is not there. So therefore, we conducted a study, and in the actual one, and to assess the psychological stress, and this because violence also affects the doctor-patient relationship. So in this particular paper, in this particular presentation, I'm going to present the findings with the objective of the frequency of violence faced by the doctors, then the type of violence faced by them, and also the reasons of the violence and perpetrators of the violence. So this was a cross-sectional nationwide study. It was conducted, time period of data collection was 3 months out of the 6 months from November 2019 to April 2020. 3 months were given for data collection from December. And then we included all the allopathic medical graduates and postgraduates and the super specialists who were practicing in private sector or public sector in any part of the country, and who had at least 1 year of experience after doing their graduation. So we used the study tool in form of Google Forms, in which the questionnaire was semi-structured, and because it also included some of the structured questionnaires, and also it was the study tool was kept anonymous. That is, we didn't collect any of the names, and we also didn't collect any of the email addresses. So the sample size was 461, which was calculated using Krejci-Morgan formula, and we used the convenience sampling technique for data collection. So we got around 617 responses, out of which we found that 77.3% of the doctors had ever faced workplace violence prior to the filling of the form. Now, this finding is somewhat near what has been reported by the Indian Medical Association, which has said that 75% of doctors have faced violence. So if you see look at the table here on the right hand side, you will find that although the doctors who were in the age group of less than 30 years and were males or were unmarried or had an experience of around 5 to 10 years or were practicing in the urban areas, faced more violence, but actually there was no significant difference among the different of the doctors in different social structure or the different regional anything. There was no significant difference. This means irrespective of wherever they are practicing, so they are prone to this violence against doctors. Now in the next table, here we show that the distribution of the participants as per the type and severity of violence, and also the frequency of violence that they faced. So if you see that prior to 1 week filling of the form, at least around 24.5%, that is around 1/4 of the doctors had faced some kind of violence. In this table, we have categorized the violence or classified them according to the higher severity of violence they have faced. This means if the person has faced say intimidation, they might have also faced verbal abuse with it. We have classified it in intimidation only. And previous studies have shown that mild violence is most common, but in our study we found that if this moderate violence, the severity is most common among the Indian doctors. That is combination of verbal threat and intimidation. Then in the next table, the reasons of violence that we found out was that non-improvement of patient condition was the most common cause of violence. And the second most common cause, not far behind from the non-improvement, is perception of wrong treatment given. Now here something Googling of the treatment and then again asking the doctor that you're not providing the right treatment is somewhere in the picture. So, and perpetrators were mainly the family members and relatives or the friends of the family, and in some cases, patient himself or herself. So, in conclusion, I would say that the prevalence of violence against doctors in India is is very high, and the more concern is the moderate severity of violence is high. And as I've already said that the most common reported causes actual or perceived non-improvement, and family members are obviously that because they are emotionally involved with the patient, so they are the main perpetrators. Thank you. Hello. Hello. Hello, am I audible?
Are there any questions?
Hello.
Are there any questions?
Thank you, Dr. Mandeep. No questions.
Thank you.
Now we will move on to the next presentation by Dr. Swapnil Tanerjee Sangle on an online study to assess the disposal of personal protective equipment at home amidst the COVID-19 pandemic. Dr. Swapnil, you can start presenting now. Hello, Dr. Swapnil. Is this PPT visible, sir? No. Swapnil sir, are you able to hear us? Swapnil sir, are you able to hear us? Dr. Swapnil is having some network issues. So I would like to thank Dr. Balbir Singh Deswal, Professor, and Dr. Anurag Srivastav, Associate Professor, as well as Dr. Sonam Maheshwari, Assistant Professor, for your valuable guidance. And I would request the chairpersons to please fill the feedback forms and mail to us the same. Thank you, sir. In your slide, I have chatted that the session is over, but if you want to present, you can, because Dr. Balbir Singh Deswal is still there and Dr. Sonim is there. Yes, sir, but we can't hear you. If you speak, can you speak into the mic, please? But we can't hear anything, sir. No, sir. Okay, fine, sir, I will try that. I don't know the system for that. Okay, I will try to put the phone in speaker and you can start speaking. Fine. Okay. The session is open for discussion now. Any discussion regarding this? Sir, you can discuss with the evaluators if you want. If there are no questions, we can just conclude the session now. So thank you, respective chairpersons as well as the presenters. You all did well, and the results will be declared by the end of the day. Thank you, sir. You can join the other halls now. Thank you, Balbir sir, for listening to us so patiently, and Dr. Soma Maheshwari ma'am also, as well as Dr. Ashutosh Mishra, Dr. Nausheen Zafar, and Dr. Swapnil. Thank you, sir.